Welcome, everyone. Today's discussion or debate will be on whether an international exposure or an international training will make a difference in your surgical career. I mean, there are very differing viewpoints. I had the good opportunity of training for 13 years here in India and then going abroad for a couple of years. And I had the best of both worlds, I should say. And I really thought that because the world has completely opened up now, and it is not unusual for you to go for short-term training, it'll be very exciting to hear the different viewpoints for the youngsters so that you can plan your career ahead. So today we can start with Maheswaran Pichimuthu, and Patta sir is here. So I want to hear both the sides of how an MCH training can happen. And Mahesh has had his HPB training from Edinburgh and Birmingham before moving to Cleveland Clinic. So the first question is to Maheswaran.
Yes.
Are you there?
Yeah. Can you hear me?
Yeah, I can hear you. So can you share your experience over a couple of minutes as to how you saw your training in Edinburgh and in Cleveland? And how did you feel when you actually applied in clinical practice? And I will also provide a counterpoint. Me and Patta Radhakrishna sir will share the MCH experience and the post-MCH experience. He has worked in AIMS. So we would also share that experience. So we'll take about 5 minutes to do the whole thing so that it becomes an introductory point. So Mahesh, you go first.
For me, the Indian experience is after postgraduate training, I didn't have any Indian experience. And the Indian experience I'm having right now is a transplant and HPB surgeon in India in the past 1.5 years. So I can mainly, explain about my the overseas experience rather than an Indian. Because so I can also compare the training that I received in India as well as in the overseas. So I worked in the UK for almost like 12 years and almost 2 years in the US. So when I was in India, I can tell you the good side of India is you will have like number of cases is quite high, and you will see variety of clinical cases, and you will be able to do a lot, especially during your postgraduate and depending upon the unit that you're working. But what I felt was like when because I didn't have MCH experience, I don't know how people will do during the MCH, but I didn't have much opportunity to do any high-end procedures during my training in India. But I can tell you, when we moved abroad, it's not only about cutting chances, it's all about the complete shape of a surgeon, which includes non-surgical skills as well. So you will be trained in decision making, and you'll be trained in leadership, you'll be trained in teaching, and you'll be trained in operative skills as well. And they're all like quite structured training. So you should have like a set goal for you to do during a course of some time. So what it helps you is like you will be moving towards the good all the time. So for example, I can tell you in the UK, initially I was not in training, but I was working in a non-training setup, but still I have to go for what's called appraisal every 6 months. So you will be periodically being reviewed, and you also have the chance to reflect how you have done in the past few months or something like that. So that actually stimulates your thought of, oh my God, what I've done in the past few months. Have I done something different? Have I learned something new? So these type of thought-provoking thing was not there when I was in India. So I think that make me think like the system is structured and thought-provoking. On top of that, the more you go on a training, they have like a set goals. For example, I can tell you the surgical training is quite long, like 8 years, and they'll have the expectation. For example, if you're like a level 4, because the ST4 level, they don't expect you to do the whole, for example, anti-resection or something like that. They won't expect. They will expect you to just put a scope, just mobilization of the colon. But when you reach the higher level, then they will expect you to do the whole thing under the supervision. That the whoever is the assessor will be standing behind you rather than doing the procedure. So you will have the opportunity to do a lot, and you also can put a lot of your thoughts into it. They'll always encourage that. That's what my feeling about the UK training. And obviously, you know, Ilango very well about the US training, how they train you over there. It's like working under pressure as well. Like they'll push you to the limits. That's how they train people compared to what is in the UK, where it's not like a pressure, but they have like a structure. And, you know, you have to reach set goals at set time points. So you will be able to reach that goal. And importantly, I think you were mentioning about the debate on whether the surgical skills are good or the decision-making skills are good. Like that was a debate that you were having before. I think the training in the UK actually balances both. Like you will be trained in decision-making a lot, and you will be trained in the surgical skills as well. But again, the disadvantages, even you are qualified, still you will be working, you know, with a team of doctors rather than you just here. It's like once you finish your training, it's a kickstart. You go and do whatever you want. It's not the case over there. It's like still you have to slowly develop newer skills during the
So,
as well.
so Mahesh, your key factors was that the you learned good decision making, good surgical cutting chances, a training in which you are constantly praised. The training makes you feel that it is very structured, and you also learn leadership skills.
Correct.
So I want to hear from Patta sir, because he has gone through the MS, MCH, the post-MCH experience in AIMS, everything. And I want to hear Patta sir's thought on these 5 points: decision-making, leadership, surgical cutting chances, appraisal, and structured, and how he felt in the Indian programs at various levels. I mean, AIMS is comparable to some of the best institutions in the world. And I want Patta sir to share his experience on that. Patta sir?
Unfortunately, being the host, Ilango, I am a member of every panel discussion, whether it's thoracic surgery, plastic surgery, pediatric surgery. But then I think you run the risk. But again, I may ruffle a lot of feathers. We have to speak the truth, unfortunately. When I went to Delhi after the MS General Surgery in Stanley and MCH GS surgery in Raj Medical College, Dr. Nandi, the boss, asked me, what is the commonest cause of upper GI bleeding in your institution? I just blinked for a while. Is it bleeding duodenal ulcer? Is it cirrhosis? I said, sir, I do not know. Then he said, what is the elective operative mortality in your unit? I said, sir, I do not know. What is the commonest cause of intestinal obstruction in your hospital? I said, I do not know. I thought these are all strange questions. You know, it started from there. Then I realized that how much we are lacking in so many things. What is the sort of annual operating list turnover in your unit? At the hospital per se, what is the mortality? What is operating mortality? Nothing new. From the scratch, I had to learn there in that institution. That is one part of it. Then when I realized how much documentation, how much auditing, how much all the statistics are important. Because if you do not know, how can you compare yourself with any other institution or any other? You're just blind over there. These areas, unfortunately, are not done, and many of these things are unknown, let's say. Now, again, protocol, like what is the bowel suturing technique they follow in your institution? I want to tell him that, sir, in our general surgery, there are 7 consultants, and 7 of them do their own way, different way. And in a specialty surgery, the boss does his own way and doesn't tell why he does that. And there's no way we need to compare with anybody. And so then, what is the size of the anastomosis you follow? I just, from theory, from textbook, I say, sir, 5 centimeters. Just like that. There you have to, as was spoken by Maheswaran, that of course, Dr. Nandi is a born brought up Briton, so he followed all that. First and foremost thing I noticed is that after 2 o'clock, the day does not end, which happens in most 2 o'clock, 2:15, we will be having lunch in the thing, elaborate lunch with all sorts of ingredients, and by about 2:45, we hit the bed. And we snore till 5 o'clock. I mean, that is the thing. One day I was disappointed in the afternoon. Dr. Nandi asked, where do you go? I said, I went for lunch. All hell broke loose. I said, lunch? Then my assistant told me, don't talk about lunch. Then I forgot lunch from them. It's not that it's that rude or ridiculous, but, as Dr. Rajasapati was talking in the morning, see, there's no working hours. There's nothing. If there's a case, something's, you're there. We used to have work till 7 o'clock because the boss is there till 7, and our main work, non-surgical work, starts after 7 o'clock. Our seminar room with all the lights, everybody there from 7 onwards. See, hard work is something which I learned over there. The more important thing is, one day he asked me, what is the blood sugar of that girl? I didn't want to ask him which girl. I said 92, just like that. He said, come, we'll go check. Then imagine my position. I just guessed. And I realized from then on that you should never tell lies. Honesty is the most important thing. There are so many little things. I never knew how to present a case properly, the way it should be presented. See, case has to be presented in certain manner. Suppose if you're in a fast round, you present in a certain way. First post-operative day, you present in a certain way. Patient just admitted, you present in a certain way. There are certain methods, all those things you have to learn from the beginning. I had to unlearn what all I learned and relearn many things. Auditing, I had to learn. How to speak in public. Dr. Nandi takes it on himself to just make sure that all his resident registrars will learn each and every step of how to make slides, how to present. See, it's a wholesome thing. More than anything, the auditing technique. See, Dr. Nandi is of the belief that he has got something to learn from everyone. It's not that, there's one of the days in the week, the round is this way. Everybody will ask Dr. Nandi the questions. Usually it's the other way. But one particular day in a week, we only have to ask, he'll not ask anything. And he has to answer. And if you have anything good to say, he'll listen. And if you're very reasonable, you have evidence, he'll follow. See, change is an important thing. And I can't tell my boss in Madras Medical College saying, sir, no, I don't agree with this and we have to change. This is not, I don't dare. Nobody dares. See, that's the way it is. So, if you allow me, I'll say so many more things, I think which I'll say in due course of time, but that's where I am.
So,
can I add one thing, Ilango?
Sure.
Can I add one thing? Dr. Patta was mentioning like the audit and the questions and how, I can tell you, people may laugh. When I was in training, we have to have a series of what's called non-technical skills. And it's like a simple, I have to spend a day for what's called negotiation skills. That means you have to go, how do you request the radiologist to get the urgent ultrasound scan done, urgent CT scan done? And how you request a nephrology colleague to come and review the patient.
I'm sure any postgraduate student working in any government hospital in our place will score very good, you should ask the
people. But the thing is, now, I'm not saying, we are all very good. I don't deny that. But the nitty-gritty of thing is, they conduct a course for this. Like, you have one special day for leadership, one special day for presentation skills. On that course only I learned, when you put a slide, you cannot have more than 6 lines. The line should not have more than 6 words. So these are all the things that you will get to know. I mean, what Dr. Radhakrishnan is saying is like, Dr. Nandi must be very, very good. He trained him very well. But I can share, I've been trained in Stanley as well during my postgraduate training. So I know how Stanley is. We have a lot of chances. But exactly what is it like? If somebody asks me the same question, what is your unit's complication mortality? I would have been thinking as well, because we don't think all those things,
Yeah. That is the biggest problem we have. See, I trained I did my MS from Trivandrum Medical College. On the first day, I went to the hospital. They said, okay, today is your first day. You should go to the casualty because it is your admission day today. So I had no idea. I did not know Malayalam. So I went down there and I said, sir, I am first year PG. Very good. There were 2 interns and one of them, Beena, became an IAS officer after that. So Beena and Sriram were the 2 postgraduate students. Sriram is a pediatric cardiologist now. And those amazing guys, I used to tell them in English, they'll translate it to Malayalam to the patient. And at one point of time, I went in to suture a patient. And the whole evening, I was continuously going from one patient to another. It was a huge volume. And by the end of the day, I was completely broken. But if you ask me after 1 year, I didn't even know how many head injuries were admitted to my unit. And I had no idea because none of them were audited. At the end of that year, an assistant professor took interest to look at the thyroidectomies that was done in Medical College Hospital, Trivandrum. I think at that point of time, they had some 1,400 plus cases. This is an approximate ballpark number. It was a huge number of thyroidectomies that were done in that single institution. I mean, you can conduct any kind of study with that kind of data, with that kind of volume. But we never audit our own data to look at those results. We did not know how many FNAs were positive, how many of them had goiter, how many of them even had disfigurement, and what was the outcome, how many of them had hypocalcemia after that. We just didn't have that data. And without that audit, there was no learning experience. So when I passed out of MS General Surgery, I started noting down everything, even if the numbers appeared very small. They looked silly at that point of time. But for my own learning experience, I just noted it. And when I started looking at those data after some years, I sort of started looking stupid. This is the whole number of cases we are doing. Like in a private practice, you'll hardly do 4 perforations in a year. That's as much as you can do. And your number of appendicectomies is about hardly about 3 or 4 a month. That's it. And most of them you're dealing with diabetic foot, inguinal hernias, incisional hernias. You're helping out with small stuff, trauma, surface trauma, breast lumps. Then only you see that what we should learn as general surgeons. That changed my attitude. But again, I came to GI surgery. GI surgery training was slightly better than that. But what was really striking for me is that I was 43 years when I went for transplant training, and I was a practicing GI consultant in surgery for 4 years. And during my liver training, Dr. Humar took me on a Sunday and said, listen, you have to learn how to present your data. And it was really like, you have some bit of ego at that time. But I said, okay, you teach me what to do. And he changed the way I presented. For the youngsters, it was much more easier for me. Now I know I do it from head to foot. And I go through every system for every patient. And that was structured training. It was very structured. And now I am able to do it on all the sides. So in India, we had the volume, but it was unstructured. In US or any other program, we have low volume, but the program appears more complete because it's structured. Now I want to put the next question forth the next question to Patta sir.
Yes.
So my question to you is, sir, given a platform like Learning General Surgery, where we are listening to a lot of lectures, and I also sit through some of them to listen, are we structured so that the information stays with our listeners for a long time? Are we structured in our lecture, or is it that our Indian training, Indians learn differently from the West? Like if you see the COVID epidemic, they have very less information, but they have tried to structure it. And despite that structuring, most of the Western programs seem to have been faltering. They are burnt out, unlike the Chinese who have actually done a good job on the COVID front. So do you feel that Indians learn differently from the Westerners? So that is the summated question. Do you think our Indians learn differently and we should approach our learning differently?
Yeah, I think we learn very, very differently from the rest of the world is my belief. Because I listen to more lectures than you do, Ilango, because I have to listen to all the lectures. Yeah. And, because I need to shut some people off, just keep interrupting. The point here is, of late I'm wondering, especially the lockdown period, that how we can, how learning general surgery can influence the surgeons or students of surgery. First and foremost is we are all technique-oriented people. See, we love somebody doing some advanced technique, some robotic Whipple's procedure. You may not do that at all, but if you have a lecture of basics or why one should do Whipple's on one side and somebody doing robotic surgery, whole audience will be watching robotic surgery, which is not relevant in the first place. Why should we do is what is important. We attend workshops that do some advanced abdominal wall or laparoscopic surgery, but we don't look into the basic anatomy or the need for it. I think the focus should be so much on those things. Why should we do? What is the rest of the world doing? Why are they doing in a different way? What is the comparison? Why do they find certain techniques wrong? Why do you find certain indications wrong? We don't go into all these areas. If you finish MS general surgery, when will I do lap poly? When will I do a lap hernia? When will I do? That's all the thing. From then on, learning is everything to do attending workshops. I think we are all technique oriented, or rather say this is not exact, this commercial surgery.
You are right on dot, sir. I think we are obsessed with learning different techniques. And
one more thing, Ilango, sorry to interrupt. One more thing.
Yeah.
What I felt after interacting with a few people here in India is like when they learn something, obviously when they learn in a unit, they learn only one technique, one way of doing that. So they think that is the gold standard. And they are very uncomfortable to go out of that box. And the training in abroad, where I was trained, you keep changing hospital every year. So what you do see is the same procedure being done by different people, but they will have their own, reasons for doing that particular way. So what they also, even though they are doing that way, they won't force you to do that. Even I do tell my junior colleagues now is, you learn from everyone, pick up every step from everyone, and form your own way of doing the case, which is comfortable for you. I think, that's how the system should be. But I don't know what I'm thought of asking. There are a lot of general surgery audience here, like the current trainees. And I don't know, the system might have changed now. A lot of people might be doing a lot of audits, journal clubs, presentations, and all those things. So we are talking about our olden days. I just want to know the trainees' view on how they are getting exposed to all those things.
So I'll put it differently. When I went for transplant training, I was closing the Gibson incision for kidney transplant. It is a right for the younger postgraduates. It's a right iliac fossa incision by which you do a kidney transplantation. So having closed abdomen since 1997, I said, okay, I'll do it. So I asked for looped nylon. So they said, loop PDS. I said, okay, what's the big difference? He said, I am the boss here. You do according to what I like.
That is US.
And I was like, how can you say that to me? So I just we are Indians. We always nod our head, even though we are rebellious inside. So we always say yes, yes, yes. And I just closed. And when I came out, I asked, what's the problem in using nylon? He said, I am signing the case, so you have to do my way. So, I just kept my mouth shut. We had 4 consultants, and I had notes for every guy's individual surgical technique, because I had to assist and I had to do the surgery with them most of the time. After 1.5 years, I was doing a liver transplant with Hughes, and I said, Dr. Hughes, what do you want me to do? He said, Ilango, you've done 1.5 years of transplant surgery.
You should know by now.
Do it your way.
Yeah.
You should figure out. Don't tell me that you're doing Hughes way and Humar way or Stodeman way. That's not right. You should know what to do for your case. Or what are you comfortable with? By the time I had lost. So what you should do as young postgraduate students, this is something you should learn. You assist as many surgeons as possible. You do surgery with as many surgeons as possible, learn as many techniques as possible. But at the end of the day, by the time you complete your training, you should evolve a method that works for you. Like I have a certain way of holding and putting.
If I interrupt here,
Yes, sir.
see, I mean, that's a very good advice, you know, but
Ah.
unfortunately, which is the best way is very difficult for anyone. No, see, in the Delhi unit, which I'm talking about, everybody should follow the same way. Everybody. Different people from different places come and do, but they cannot do their way. I think that is very important. Every surgical unit, training general surgery, they should have a certain standardization as far as technique concerned. In Delhi, everything was changed. I had to hold a needle hold in a particular manner. I had to use a particular suture. The incision should be of that particular length only. And then, you know, for everything, there's a particular, this is a standard, and that I had to follow. After a while, now in my unit, everybody should follow my rule. People can't do, if you're doing on your own, you do whatever you want. But in my unit, the small ball is sutured in by a technique called Smith technique. Everybody should follow Smith technique. Why? That's how I trained, and I found the results are very good. I mean, I think that those things become important.
Correct, sir.
Perfect.
Correct.
So,
but you know, one thing like for you know, you said you want to do in one particular way. That means you know, if we have a reason for that, obviously everybody would like to follow that. But I felt sometimes you have been forced to do in one way, which may not be comfortable for you. What do we do in that situation?
No. Mahesh, I think the unit protocol and policy is something
that has to stay. That has to stay. I agree completely.
Yeah. So, okay. So from here, from a point where you have a single technique that suits your own hands, that which you are very comfortable with, is probably very, very important. But it is something said like Patta Krishna sir has learned it in India, and I had the same experience in the US. But having been trained abroad, you had the experience of working with multiple people, but you share a very different view. So probably for today's discussion, I think we can have a whole lot of discussion on the individual technique. But what I want to do today is, how did this influence, a Western influence or a Eastern influence, whatever it may be, how will it help a postgraduate student? We should see it from their point of view. So
I think we'll throw open for some of the comments from them.
That's what we want.
If anyone wants to comment, please unmute yourself and give your comments.
Please do.
Maybe you can start with Meghna. Yeah, Meghna.
Sir, I have. I'm from Mumbai, and I've been planning for a good exposure for UK or US. But somehow I'm confused because I get different opinions, like life as you get in India is not like that, and you will be under pressure system and many more things. And it is easier for a person to go and study for a fellowship or something like that in UK than US. It's better that you progress your career in a right direction in India rather than spending time in US preparing TOEFL and all those things. And in that time span, you can be a better off surgeon in India compared to UK or US. So I don't know, sir. I want your opinion.
So Meghna, you put the right question actually. So would you prefer, I mean, for young surgeons, this is the key question. Would you prefer starting your practice early and establishing yourself locally, or do you want to take a chance and go abroad? So that is the question I asked myself, but I'll take Maheswaran's opinion on this. And if there are any other postgraduates you want to say a different viewpoint, you please unmute and you can participate in the discussion. The whole aim is to encourage you to participate and throw all your questions at us so that we can attempt to answer.
Hello. Good
Harish? Harish, yes, go on. One at a time, please.
Yeah, Priyanka.
Hello, good evening, sir. I am Dr. Priyanka. I have just passed my MS from Grant Medical College, Mumbai. So,
So you have to speak up a little bit, Priyanka.
yeah,
Closer, louder.
I have
Yeah.
passed out this year from Grant Medical College, Mumbai, this year in general surgery.
Good.
And so this is like the same thing that has been going on, like in my mind. I've already cleared MRCS Part A, but the main confusion that is right in front of us is to go through the MCH, which is that like we know it is a structured program and we know what it's the outcome will be, or just going to the UK, which is like a complete unknown terrain for us, and we really don't know what actual training, what exposure, what exactly is going to happen to us there.
So I'll give you an initial tip on that, okay?
Thank you, sir.
If your intention is to come back to India, you definitely need an Indian experience, okay?
Yes, sir.
So the kind of diseases you see here are slightly different from the patients you see here are slightly different from the ones you see in the West. So if you work hard as a general surgery resident, you get 3 years. And probably if you are a senior resident, you get another 2 years or so of good surgical training. That's a good Indian exposure. So that sets a good foundation for going abroad. And even if you stay for a short time at that point of time, you will definitely benefit out of it. This is my thought process. And I would like like Patta sir and Mahesh to comment on this as well. So even a short time, you go for a short time, you will get well. And if you go for a structured training after 3 years of MS general surgery, you really do well abroad because you already have a foundation. And those guys are very, very good at polishing your good foundation. And you can do very well. And when you come back, you still have the Indian experience. This is my thought process. But I would like to hear both Patta sir. Patta sir has had the experience of working in Bangladesh and in Sri Lanka as well. And I would like a comment on how he felt that the Indian experience compared to the experience of doctors in both those places.
Yeah, before that, I'll ask Maheswaran to respond to her regarding the UK training. Then I come.
Yes, sir. I can tell, I finished my MS before I left UK. So when I went there, it was actually quite easy for me. And people suddenly recognize that I'm the only one, I don't know, maybe a few people. I didn't do what's called a senior house officer job. I directly went for a registered job. I've been, doing the surgery from the beginning of my career in the UK. But not everybody gets the same. Now the system has changed a lot. Now they are giving more importance to local trainees in such a way that once you finish your training, for example, if you want to get into the surgical training, you should not have passed a certain years after finishing MBBS. If you have finished, for example, if you finish your surgical training in 2015, they have 3 years time. So after 2018, you may not be able to apply for surgical training. So there are a lot of difficulties in getting into the training. That's for sure people will have. I think for Priyanka's question, it's like, what is your aim in life? If you want to settle well in India, and if you've got general surgical skills, and if you know how the MCH is going to, the program and curriculum goes, and you'll be able to get MCH degree here. And I think that is the good way, like you can, if you decide to stay in India, then you go on doing the MCH and settle here and, build your career from there. But if you want to have a different experience, or if you want, for example, I've never thought about doing a transplant surgery when I was in India. But when I went there, after seeing a few cases, I developed interest in transplant. I pursued the transplant, I got it. Here also now the opportunities are being open now. But I can tell during my time when I went to the UK or US, there is not much transplant activity happening in India. So I would have lost, if I wanted to transplant, that is my passion and interest, I would not have been able to do that if I stayed in India. So actually you have to balance what you want to do in life. For example, if you want to go for some higher specialty or where you want to do more things and get different exposure, better go to abroad and get it. And I think I agree with Ilango, even if you want to stay in India, to just have a flavor of how other people work, it's better to go to some higher centers and see how they are working. That actually gives more insight for you to to what to do in future. That's my way of explaining what Priyanka needs to do.
Thank
Yeah,
you so much, sir, for learning
Priyanka,
things. Yes, sir.
there's no place like India
Yes, sir.
to start with. No wonder Ilango and Maheswaran came back to India after being in the US and UK, and many more. I come back. See the present situation, how the medical situation is in the UK and US. And COVID has come changing each of them, and the point is the major issue here is you do MS general surgery, go to UK, get trained in hepatobiliary or colorectal or whatever, and get a fellowship and come back to India. People don't accept you as a specialist. In India, degrees are so very important. It's important for any corporate hospital, important for any government sector, even for patients. Nowadays, MCH, DNB is the rule. If you do not have them, Dr. Selvi found it very difficult to be accepted as a oncoplastic breast surgeon because she doesn't have MCH oncology. But that era is over now. That not having specialty is not going to help anymore. So my take is, Priyanka, to everyone, the youngsters, finish off all your education here. You don't anticipate that you'll go abroad, get trained, have to come back and do MCH. It's not possible after that. You have to finish all your education and then go for advanced training. And that's going to, as Ilango says, that they're going to sharpen your, they're very good at sharpening your skills which you already possess. So, and again, in the morning, if you listen to Dr. Rai Sabhapati, somebody asked me, sir, is MCH important? I think it's very important at this point of time. More so because more and more MCHs, more and more DNDCs are available now. There were only 2 to 3, when we were studying. So, it's important that you have to prepare, and once you have a qualification, you can always come back, learn the operative technique and other protocols elsewhere and come back and then right while you practice. You have both Western as an Indian qualification. That's my take, Ilango. Bhavik has got a question. What is that you want to ask, Bhavik?
Sir, I'm Bhavik. I want to just comment on the abroad learning. So I think not most, but many of the people just go outside or abroad because of they are getting the brand, the tag of the training which he or she getting from that outside of country center. So it is just sake of the brand name because it will give you a more reputed in the local area, because one of the person is trained outside the India, so he may get some brand. Or out of it, the learning process may not be different from that in Western or Eastern, but what he will get in is the brand or tag of this training.
You think the brand which no, that may not be true. It's not the brand, it's a training, it's a protocol, it's a discipline, so many things to it. Yeah, Ilango, back to you.
Sir, so in MCH, I'll put forth one more question. Okay, the MCH training in India appears to be completely varied. So I'm just playing the devil's advocate here, and you may have an extremely structured program in AIMS to a completely unstructured but very friendly program in Trivandrum and in Chennai. So I'm just playing the devil's advocate. But if you go abroad, there is a feeling that whether you're in Cincinnati or in Bristol or in some godforsaken place, you still get access to a structured learning program. This is probably is it just a general opinion, or do you find it true? Let me summarize. Is the training in MCH just plain luck? You get into a good program, your luck, or otherwise?
Is any MC students there?
Yeah. If I had to ask me, Ilango, my take is, of course, it's all a matter of luck, and of course, all your excellence also, because if you've scored more marks, it's likely that you get into a better institution. Whatever said and done, degree is important. Somebody told me, when I was doing urology in All Institute for a while. Then I got gastro in Chennai. Then one of my seniors told me there, see, it's just this is a paper. A degree is just a paper, but it will have worth depending on how you train subsequently. See, you have to add value to it. But then after a while, see, for instance, if you do emergency surgery, go abroad, get trained in some specialty, come back, if you don't have that paper degree, you regret that you do not have, because I'll tell you about my own unit position. And somebody who's not done a degree but had good training in GI, been there for a while, and one MCH person joins who's about 5 years junior, he'll go over because he's got a qualification. He'll be promoted as a consultant, and when the other person, because do not have a degree, salary differs.
Yeah.
Salary differs tremendously, and it's so hurting. And all the junior people, MS level registrars, they'll only respond to that MCH person who may be very, very junior, but not to the other person with experience. In India, the system is totally different. So again, I'll go back to my point saying, get the degree, wherever, whatever, you learn your own way, and then go abroad.
Can I add only one thing? I agree completely with Dr. Patta sir. Degree is very important, but I also agree with you. It's a bit of luck where you get trained in your MCH, because I've seen two people with MCH, and one from Chennai, one from somewhere in North India. I don't want to say exactly where it is, but I can tell, one person who's trained in Chennai, he's a very hard worker. And now, he started his own practice after finishing MCH GI surgery, and he's doing really well. And he's also started doing Whipples and livers and all those things. The same MCH qualification from different institute, the person comes and asks me, sir, how do you do difficult lap chole? Because we never got exposure. We do all those major surgeries, but we never do lap chole. And I have to train him for laparoscopic cholecystectomy, which is a bit difficult for him. So when I watch him doing that, sometimes I have to be a little bit nervous. Oh my God, is it going to be some disaster or something like that? So that makes me feel like what training they have received during the MCH. This is like lap chole is the basic, training and surgery to be done by all the emergency surgery trainees now. But the MCH person is struggling, and actually, in fact, he said he's not comfortable doing a lot of laparoscopic procedure. He's going for further training now. So that is the situation. It's actually what he said is right. It's a kind of luck. Once you get into good unit where you get a lot of exposure, a lot of opportunities, you will do really well. But if you go to a unit where if it is not good opportunities, or if it is may not be a good unit, not number of cases, probably you may struggle in your life in future. That's what my take. After seeing these two people.
So for youngsters, I'm sorry. You can go ahead, ask your question. Please do. Yeah, please go ahead. Bhavik, please go ahead. You can unmute yourself.
Okay, correct.
So when we were, my father was a general surgeon. So I became a general surgeon when I was 27 years old. And I was very proud. When I stepped out, my father told me that just getting your MS does not mean that you're a master of surgery. Okay, it just means that you're a good student of surgery. I mean, it was a little insulting at that point of time, but I think I find it more truer than now that I have come so far. When you finish your MS, it just means that you have been a good student of surgery in those 3 years. So with that mindset, if you can start, it'll be good. But when I went like that for 7 years, and I met one of the professors of endocrinology and from the All India Institute of Medical Sciences, he advised me and my wife. She was an MD in general medicine, and I was an MS in general surgery, and we had been practicing for 7 years. He said, your basic medical degree, is your DM or your MCH. I mean, that is, he said, we were shocked at that point of time. What does that mean, that we have wasted 7 years of our life? I mean, I can never be sure. Right? Those 7 years of experience still helps me a lot. But I agree with Patta sir. In India, it is not just, it is a basic degree. Now your specialty degree is a basic degree. But that does not mean at the end of your specialty degree, you get everything that you want. you have to still learn. And that is where I believe an experience abroad definitely adds to your cutting edge. And wherever I have gone, whatever specialty, there is always something to learn from the West. Patta's neurosurgery colleague in SIMS, he is one of the senior most neurosurgeons in the country. And he gave a beautiful lesson to me when I was a consultant in GI surgery. He said every 10 years he used to go abroad just to see what new techniques have come up. And in the first decade when he went, he was so surprised with the amount of development that was in US. And then when he went the next time, he's Dr. Suresh Babu. He's a very famous neurosurgeon. He's the doctor's neurosurgeon. So when he went the next time, he told me that he was doing as good as them. And with the 30th year, I mean, when he went the third time after 10 years, he said he found himself much better than them. So you can keep abreast of your own on your own, but you can also assess your own skills by looking at other surgeons. Another good lesson I learned from Dr. H. Ramesh, I found one of his CVs lying on his desk one day. And I found that every year he has been traveling since his MCH days. So he has visited quite a few centers and picked up techniques from there, which has helped him become a better surgeon with each time. And one very remarkable story he tells of a Japanese surgeon who wanted to see the way he was doing pancreatic surgery. And he was very honored to see that upper GI surgeon trying to learn some technique from watching pancreatic surgery. So we all are in different skills. You know, it's the most important thing is that you utilize that. And I want you to remember that going abroad will not solve all your problems, but going abroad will give you an experience in a different lifestyle, a different perspective. That is what I want you to learn out of this debate and discussion. Okay. So I saw a question raised by one of the youngsters here. Let me go to that question. If you have any other question, please do put up your Dirush.
Yes, sir.
You're finishing general surgery in 2 months. You're interested in urology and you're interested in working in the UK. Your advice, please. So UK, I think, Mahesh, can you take that question?
Of course. It's depending upon what you want to do. If you just want to go and experience and come back, then you can go over there. There are plenty of opportunities, but they are all not training positions, but still you will be treated like a trainees. You will have the opportunity to see a lot of things. But if you want to go and settle over there to become a consultant, they have a strict, requirements, like you should have finished the training over there. That at that moment may be difficult. So, I've recently, one of my, couple of my DNB PGs from our hospital went to UK. They're actually doing really good. They keep sending messages saying that how they feel. What they feel is they're seeing, different way of life, different way of doing things, and different experience. They are all planning to come back in another 3-4 years time. If that is the case, I would agree with you saying that after finishing your emergency surgery, if you have some specialty interest, for example, if you want the colorectal, hepatobiliary, upper GI or something like that, then you can specifically choose those type of jobs you can apply, because a lot of opportunities, as I mentioned, but you have to finish your if you have finished MRC, it's very easy for you to go over there and get the training and come back. As Ilango mentioned, polish yourself in all the techniques. When you come back, I think you'd be a good surgeon here.
Thank you, sir.
Dirush, I would like
Yes,
to
sir.
add one more,
Yes, sir.
Whenever you make a decision to go and train abroad,
Okay, sir.
one must always remember a few things. One, it might be a one-way ticket. Sometimes you will stay there, and Western systems have a very structured way of moving forward. Okay, in India, you can finish your MCH. 4 years later, you may become the lead surgeon in a program, but it is quite unusual for that to happen in UK or US. I'm not saying it's impossible, but it can happen. I worked with a very brilliant surgeon who was a transplant trained surgeon from Cambridge. He and his colleague, both are Indians. Okay, one is a South Indian, another is a North Indian. both were advised by one of their senior colleagues, listen, in UK, you have a glass ceiling. You may not be able to progress forward. And they opted to go back to India. The North Indian colleague had an opportunity to go to US. Okay, he cleared USMLE. He got a fellowship program in transplant surgery at Pittsburgh, and he did quite well. And since he wanted to stay there, so he did his general surgery residency after doing his fellowship. When I met him in 2014, he said, Ilango, you'd never stay back here. My colleague who went back to India has established a program, and he has become a distinguished transplant surgeon in the country. But I moved to US, and look at me, I'm mostly working as a donor surgeon, but I have to stay here because I brought my daughter here. She was young, she wanted to stay in US, and I had to sacrifice a lot of things. And now I don't even look for a career now. I just come here, finish my donor work, and go. I mean, things are really unpredictable even with the Western life. So,
Ilango, if I can
yes, sir.
I think we have only 5 minutes to the next meet. And I think Meghna has asked a question to which you just gave the answer. Why do Indians come back after going for training abroad? Why don't they settle? I think you answered it pretty well. As again, I'll come back to my point, saying there's no country like India.
True.
So, my remark will be, get your Indian qualifications, what all, at a stretch. Then go abroad, get yourself polished, and then come back. I mean, on that note, I think we have to close this session, Ilango.
Yes, sir. I think this is the point you should carry.
Ilango, one Tejasvi has asked a question and regarding the urology training or something. How can I just reply privately?
Patta sir, can we put up a text chat on that, and when you put it up on Facebook, we'll answer that question for her.
Yeah, fine. We'll do that, right? Because we need to go to the other.
Yeah, we need to go to the next session. Thank you, sir. Thank you, everyone, for participating.
Maheswaran, thanks, everyone.
Thank you, sir.
Okay.